Cirrhosis is a manifestation of lots of other more specific diagnoses such as chronic alcoholism, hepatitis C, hepatitis B, hemochromatosis, primary biliary cirrhosis. There's a whole bunch of different disease processes that affect the liver that can ultimately result in cirrhosis of the liver and ultimately end-stage liver disease. When we look at the liver, in general, the liver has two jobs. One is to remove different toxins from your blood that are not supposed to be there. And one of those toxins we happen to be able to measure is ammonia, not pneumonia, but ammonia. And there's no doubt lots of different toxins. That just happens to be one that we can measure, and it's a good marker of how well the liver is clearing toxins in general from your bloodstream. The other thing is the liver makes different proteins that your body needs to function. And so the one that we monitor in order to tell how well the synthetic function of your liver is functioning is clotting proteins. And so we can check an INR. So when we're monitoring your liver function, we'll often check an ammonia level and an INR to give us an idea of how we're doing. So blood comes in to the liver from a blood vessel called the portal vein. The blood comes in, it works its way through the liver, and the liver does its job, which again is to remove toxins and add different proteins that you need. And then it goes out through the hepatic vein, and the blood just gets back into your normal circulation. So the normal liver is made up of these nice smooth sheets of cells so that the blood is able to easily come in from the portal vein, work its way through the liver does its thing, and the blood goes out through the hepatic vein. So this is a low pressure system. It's easy for the blood to get from here, through here, and out there. So what happens with cirrhosis is you have had some injury to the liver. And again, there's lots of different things that can cause that injury. But the interesting thing about the liver is whenever it is injured, instead of just directly forming scar tissue, the liver actually has the capacity to repair itself, which most organs don't have. Like if you have a heart attack, you're just left with a scarred heart. Well, the liver has the capacity to fix itself, so to speak. So, for instance, if somebody were to take a toxic dose of Tylenol, you can essentially wipe your liver out, and if we can keep you alive long enough, the liver will eventually basically restore itself, and you can be left with normal liver function despite having had catastrophic liver failure. Now, a lot of people do die when that happens, but again, if we're able to keep you alive, these people are often left with normal liver function. On the other hand, as the liver is trying to repair itself, sometimes it does so abnormally. So instead of the liver growing back in its normal architecture, which resulted in these nice smooth sheets of cells and with a low pressure gradient so that the blood's able to work its way through and out, it instead grows back in these nodules. And so it's these nodules that we're looking for when somebody has cirrhosis. And so the interesting thing about this is if you stick a needle in there and pull some of this liver tissue out and look at it under a microscope, the cells are actually normal. But it's the architecture that's distorted. And you have this scar tissue that's separating these nodules from each other. And the blood vessels that normally carried your blood flow through the liver so that the liver could do its job gets tied up in this scar tissue, and we have turned what should be a low pressure system into a high pressure system. So as blood comes in from the portal vein, as it gets to the liver, bam, it's hitting a brick wall. And so we have trouble just getting blood flow from the portal vein through the liver and out the hepatic vein. And so what that does is that causes portal hypertension. This high pressure backs up into the portal vein. And so the things that can happen when you have portal hypertension is, number one, this high pressure in the liver is quite literally just squeezing fluid out of the liver and into the abdominal cavity. It's quite literally the liquid part of your blood. And so this is called ascites, when you have fluid accumulate in your abdominal cavity. And so this fluid will accumulate, and again, it's just literally been squeezed like out of a sponge out into your abdominal cavity. And so that causes your abdomen to become distended. It can be extremely uncomfortable. That fluid can sometimes get infected. Lots of bad things can happen. The other thing is, because of the high pressure that's built up in the portal vein, there's another vein called the splenic vein that is connected to the portal vein, and that high pressure backs up into the splenic vein. And the splenic vein itself goes to the spleen, of course, but it also goes to your stomach and esophagus. And so a couple of the other things that you see with portal hypertension is splenomegaly, meaning your spleen is enlarged, but you also see what's called varices, which are abnormally enlarged and leaky blood vessels that will build up in the stomach and the esophagus. And again, these things are leaky. And so a lot of times patients with advanced liver disease can have bleeding esophageal varices or bleeding gastric varices. There's also a vessel that goes to the rectum, and so patients can have awful problems with hemorrhoids. And so bleeding esophageal varices in particular can have a very high mortality. So that's a bad thing when that happens. So what can you do about the situation where you have cirrhosis? Because once you have cirrhosis, you just have cirrhosis. Nothing's going to make that go away. Ultimately, the only curative treatment for that is a liver transplant, and they just don't have shelves full of livers waiting around. So a lot of people, unfortunately, just don't get livers, and so you have to manage this. So we use diuretics to help try and keep the fluid out of the abdominal cavity, and then because of the toxins that are building up in the blood, as the ammonia level goes up, we often see that people start getting very confused. And so one of the medications we use for that is a drug called lactulose, which is basically a laxative. And the way it works is by giving you diarrhea. The patients who are on this hate this drug because of that, but that's how it works. If you're not having diarrhea, it's not working. And so basically what that's doing is the ammonia is produced in your gut. And so the ammonia gets absorbed into your bloodstream. As it goes through your liver, the healthy liver is going to get rid of it. But somebody with cirrhosis, that's not going to happen normally. And so the ammonia levels can build up. And so what the lactulose does is it gives you diarrhea, and we're basically flushing out the ammonia before it has a chance to get absorbed. And so it's really important that if you need to be on lactulose, that you're on lactulose and actually taking it. We have a lot of people coming in and out of a hospital with hepatic encephalopathy, and again, that's confusion because of the toxin buildup. Now, to help prevent the ascites, again, we can put you on diuretics for that, but the other potential procedure that we can do is, imagine if I took a tube and I put one end of it in your hepatic vein and I put the other end in the portal vein. You can see that gives me a direct conduit from the portal vein to the hepatic vein, and we're just kind of bypassing that high pressure liver system. And so we can maintain blood flow from here to here. And that can help prevent, it will decrease the amount of portal hypertension. So one of the indications for this is somebody who has had bleeding esophageal or gastric varices, and also people who have just intractable problems with development of ascites. But the potential complication of this is we're bypassing the liver. The liver's there for a reason. And so one of the complications of this procedure, and this is called a TIPS, T-I-P-S, is that patients can become profoundly encephalopathic. And so because of that, if anybody has ever had issues with encephalopathy, they are often considered not to be a candidate for this procedure. But some people are and are really greatly helped by it. Now, if you're not a candidate for a TIPS procedure, there's another procedure where we can take a tube and put one end just out in your abdominal cavity and stick the other end back into, say, the hepatic vein, just one of the venous returned back to your heart. And so it doesn't stop the ascites from being produced, but once it'll have a pressure valve, and once it reaches a certain pressure, the valve will open and it will redistribute the fluid that's out in your abdominal cavity and back into your venous circulation. The problem with that procedure is virtually all patients are going to develop some degree of a condition called DIC. The point of this is not to get into the weeds with that, but feel free to Google that. But that is a blood dyscrasia which can be fatal. So we don't just do this on everybody. And to be honest with you, it's kind of fallen out of favor. We do very few of those procedures anymore, but every once in a while we will do one. Now, one of the things we can do to improve quality of life for patients who have lots of problems with ascites we can do what's called a paracentesis. That's basically where we take a needle and we insert it into the abdominal cavity and we pull some of this fluid off. Occasionally we do really high volumes of these things. But you have to be very careful with that. Remember that this fluid is basically the liquid part of your blood. And there is a pressure gradient from the liver to the fluid that's out in your abdominal cavity. Think of it as having a pressure from the fluid out in your abdominal cavity, pressing in on the liver, and then you have a pressure from the liver forcing fluid out. At some point, those pressures equal each other and you quit secreting fluid out into the abdominal cavity. So if I stick a needle in there and pull a bunch of fluid off, well, I've upset that balance, and now the liver is potentially, and in fact probably, just going to start secreting more fluid out into the abdominal cavity. Now, how quickly that happens is really patient dependent, but I have had a lot of patients where we had really rapid reaccumulation of ascites. And so again, that fluid is coming from your blood. And so despite these patients being grossly volume overloaded, it's in the wrong place. It's not in the blood vessels, it's outside the blood vessels. And so this can cause some pretty severe volume contraction. And when that happens, one of the organs that is particularly susceptible to low blood volume is the kidneys. And so you can sometimes precipitate kidney failure if you're too aggressive about pulling the fluid off. And the one thing you do not want to do if you have liver disease with cirrhosis is to go into kidney failure. That is a potentially deadly combination. It can precipitate a condition called hepatorenal syndrome. So that's pretty much it. So this is liver cirrhosis, the complications that can occur with it, and again, some of the things that we can do to make life at least a little bit better for the patient.